Okay. Shall we start? You all can hear me, no? Hello? Can you all hear me? Yes, right. Right. Today we are going to do MCQs on vascular surgery topics. I'll try to cover chronic limb ischemia, acute limb ischemia, then the varicose veins, lymphedema, and if time permits, carotid artery occlusions and the aortic aneurysms. Triple A. Right. We'll start with this question number 48. SBR. A 70-year-old came to the surgical clinic for evaluation. He reported difficulty in walking long distances due to pain in the legs. He can walk up to 200 meters and then he has to stop for 5 minutes before he can continue due to the pain. Pain in the legs improves after some rest. On examination, both his legs are shiny with hair loss and there is muscle atrophy. What is the most likely diagnosis? Before that, can you all analyze this question, history and examination findings? What is this presentation? What happens in this chronic limb ischemia? Intermittent claudication. Yes. What is intermittent claudication? This is this patient gives history of difficulty in walking long distance due to pain. He can walk up to 200 meters without pain. Then he has to stop. And after resting for about 5 minutes, patient relieves his pain. Then he can again walk. And he doesn't give a history of pain on first step, right? And this pain is reproducible. And they haven't exactly described the character of the pain and where they got where the patients feel the pain, which group of muscles are involved. That hasn't been mentioned. Yes, what is intermittent claudication? What happens in chronic limb ischemia? Can anyone answer? What is the difference between acute limb ischemia and the chronic limb ischemia? In chronic limb ischemia, it's a gradual process. There is a occlusive arterial disease involving the vessels involving the lower limb. Someone has answered collateral development chronic limb. Yes, it's a gradual process. It's an occlusive arterial disease in the blood vessels, arteries which supplies the lower limb, right? So this peripheral vascular disease ranges from asymptomatic state to critical limb ischemia, right? So it's a gradual process. Patient at the initial state of the occlusive disease, patient will be asymptomatic. As this atherosclerosis process goes on, arterial lumen will be gradually narrowed, right? And due to the ischemic state, yes, there will be development of collaterals, and if patient is exerting while on pain. And at one stage, vascular supply will be reduced up to the level where patient gets ischemia after some degree of exertion. That is the point where they get intermittent claudication. How do you describe this pain in the intermittent claudication? And what are the differential diagnoses you all have to exclude in this sort of a clinical picture. So could you please give an overview of vascular surgery first, if possible? It will be really useful. Yes, vascular surgery, we can categorize into three parts. No? Arterial diseases, venous disease, and lymphatics, right? One has asked me to give an overview about vascular surgery. There are three main categories in vascular surgery: diseases involving arteries, arterial diseases, then the venous diseases, then diseases involving lymphatics. Arterial diseases, mainly peripheral vascular disease, then the AAA, abdominal aortic aneurysms, then the carotid artery occlusions. Those are the main topics we have to cover, right? That is where the surgeons intervene the arterial occlusions, right? Then regarding vascular disease, venous diseases, varicose veins, there is a disease of the superficial venous system, then the deep venous thrombosis, deep vein thrombosis. Diseases related to lymphatics are the lymphedema and recurrent cellulitis, right? Those are the main topics. We'll try to cover one by one. We'll start with chronic limb ischemia. That is the major topic that you will be questioned on this topic in your long cases, even in short cases, MCQs, and that this will be a SCQ topic as well, right? Right. And chronic limb ischemia, right? It's a disease where symptomatology and severity varies in a wide range, right? It can be asymptomatic, or patient, as it progresses, patient will develop intermittent claudication, and if it is further worsened, and if we don't intervene, or if it further progresses, patient will present as critical limb ischemia, right? You can see my screen, no? Can you see my screen? Right. In intermittent claudication, patient at this stage, patient doesn't have a pain. The patient doesn't feel any pain on rest, right? That means blood supply is adequate to maintain basal metabolic rate, right? But if you exert up to some degree, then with the exertion, your demand will be rising, right? Muscles will act on exertion activity. Muscles blood requirement will be increased. Due to this arterial occlusion, blood vessels cannot produce adequate volume to this group of muscles after some degree of exertion. So there will be a requirement and supply mismatch. That is the point where patient develops ischemic pain in this exerting group of muscles, right? That is what happens in intermittent claudication. It occurs as a result of reduced tissue perfusion, which are unable to meet the increased metabolic requirement of exercising muscle group. Pain developing on walking. So on walking, your group of muscles will work and demand will be rising. If due to occlusion of the arteries, if body can't produce adequate blood supply, so muscle will become ischemic. Then there will be ischemic pain. So the pain won't be appear on first step. After some distance of walking, patient will feel the pain, right? Then the pain arises in the muscle group distal to the arterial occlusion, with relief of symptoms after cessation of exertion. Once you terminate the exertion, demand will gradually comes down. So then even despite of artery occlusion, this artery system may supply the may be able to supply the demand once demand gradually comes down. So with the rest, this ischemia will be eliminated. Patient will relieve the pain. Right. That is what happened on rest. Pain again reappears after walking similar distance. That is the claudication distance, right? Again, once you will start walking and will start to exert the group of muscles. Up at one point, there will be again supply requirement mismatch. At that point, you will develop pain. Pain is not felt at rest or within the first few steps taken, because at that point, this artery system, despite of occlusion, has the ability to supply adequate volume of blood, right? Mostly felt at calf muscles, which are extensively used in walking. In aortoiliac diseases, usually if the occlusion at the superficial femoral artery level, then you will get the pain on calf muscles, right? If the occlusion involves aortoiliac disease region, that means from the common iliac, external iliac up to the femoral, then the pain will be felt more proximal at the buttocks and thighs as well as calf, right? That's what happens. When the occlusion is more proximal, more groups of musculature will become ischemic, because when you walk, entire group of muscles of the lower limb will work, right? So the demand will be rising of each and every muscle group, right? That is the basic description on intermittent claudication. We'll first discuss this occlusive artery disease, then we'll move on to MCQs. That will be easy. Then, what is critical limb ischemia? What happens in critical limb ischemia? In that stage, this occlusive arterial disease has progressed up to a level where the blood supply is inadequate even to fulfill the requirement of basal metabolic rate. So the patient develops pain even at rest, right? Even this blood supplies come down to a level where they can blood supply is even inadequate to maintain the basal metabolic rate. So the patient gets pain even at rest, right? And obviously, if blood supply is inadequate to maintain basal metabolic rate, it is obvious this blood supply is inadequate to produce adequate nutrition to wound healing, right? So if the patient gets small wounds due to minute trauma, these wounds will progress because blood supply is inadequate. Wound healing process will be impaired. So patients if they develop ulcers, that will progress without healing, and there is a risk of infection as well. So patient will, in critical limb ischemia, patient either will present as rest pain or tissue loss, non-healing ulcers, because arterial occlusion is so much severe that blood supply is inadequate to maintain basal metabolic rate or wound healing. So if they can't maintain the basal metabolic rate, it's obvious fact that blood supply is inadequate to repair or damaged tissue, right? Because wound healing requires good nutrition, blood supply, and everything, right? Significantly impaired tissue perfusion with rest pain, ulceration, or gangrene involving torso, forefoot. And usually in critical limb ischemia, there will be a lower limb vasculature will be affected at 2 or 3 anatomical levels, not only one level. Then what is rest pain? These definitions are very important. You will be questioned in your vivas and long cases. Rest pain is ischemic pain, may be constant or nocturnal. It is typically present in the distal portion of the foot, that is forefoot. Usually feel at the forefoot, often relieved by hanging the leg dependent. If when you put the leg down, that will be relieved and it will be worsened with elevation. And usually it's a constant pain, more severe at night, because at the night, due to this reduction of work, there will be this venous pump will be diminished. So there will be a venous stagnation at the lower limb venous system that will further decrease the already compromised arterial flow. And other fact is, in the night, other sensation will be diminished. You are just staying without doing anything. So your concentration for the pain will be higher. So you will feel more pain at night. That is your rest pain. Right? Unlike in intermittent claudication, in this situation, tissue perfusion is severely compromised to a level that it doesn't meet the requirement of basal metabolic rate of ischemic tissues. It causes pain at rest and inability to repair and regeneration of tissues leads to ulceration and gangrene after minor trauma. What is gangrene? Then comes this history and examination. This is your Fontaine classification. In stage 1, patient will be asymptomatic. Stage 2, there's part 2A and 2B. In the 2A, claudication distance is more than 200 meters. Usually, stage 1 asymptomatic. 2A means patient is undisabled. 2B means patient is having disabling claudication. Stage 2A, patient is having claudication, but it won't affect much of the patient's day-to-day work. Stage 3 and 4, where you have this critical limb ischemia, rest pain in the stage 3, tissue loss in stage 4. Right? Gangrene is ischemic necrosis of tissues. There will be cell death due to inadequate perfusion. And it can be either dry gangrene or wet gangrene. When the ischemic infarcted ischemic necrosis tissue superadded with the secondary infection, putrefaction, that is the point where you call wet gangrene. This is 5 classification. Yes. And occlusive artery disease is a clinical diagnosis, right? If you plan interventions in occlusive artery disease, peripheral vascular disease patient, then you should do the imaging. In symptomatic patients with revascularization plans, for you to grade the stenosis and it helps to plan the intervention, you do the imaging. Screening image, initial imaging is the duplex artery duplex scan to visualize the vessel stenosis and plaques. And according to level of stenosis, flow will be triphasic, biphasic, or monophasic, right? You should assess the inflow and outflow as well. CT angiogram is more descriptive. If the occlusion at higher level from the intradiaphragmatic to suprainguinal, then CT angiogram will be very useful. Below inguinal region, most of the time, this artery duplex will be adequate to assess the occlusion. Then if you plan to intervene endoluminally, then comes your digital subtraction angiography, right? Then comes the management, medical treatment, right? Aims of medical treatment is reduction of cardiovascular risk, improve the symptoms and disruption of disease progression, smoking cessations, treatment of diabetes, lifestyle modification with diet and exercises. These exercises improves the muscle and endothelial cell function and improves collaterals. It is called claudication pain endpoint supervised exercise program 3 times a week, more than 60 minutes per session. Should be supervised, closely observed session, and it should carry out 6 months if you're going to manage consider and reassess. Then management of dyslipidemia, antiplatelets, antihypertensives, then xylostazol for claudication pain. It acts as a vasodilator. Then surgical interventions if patient is having disabling claudication or critical limb ischemia. Right? And surgical intervention could be open surgery like surgical bypass or endovascular interventions. And if the limb is unsalvageable, then comes the amputation. Right? You to do surgical bypass, run in and run off should be good, and the occlusion should be usually if the occlusion is short segmented, you can try endoluminal intervention. If it is larger, multi-segmental occlusion, surgical bypass is more preferable. According to Vascular trial, this very popular trial, they have studied the compared to bypasses angioplasty. If the patient's life expectancy is more than 2 years, bypass is more preferable, because after 2 years, outcome of the bypass surgery is higher than endoluminal interventions. Right? If patient is not fit to bypass angioplasty, then comes this local prostaglandin injections, endarterectomy for short occlusions in high flow arteries. That's roughly the overview of the occlusive artery diseases. And you should know in this Fontaine classification, stage 2B, 3 and 4. Those are the stages where you should intervene. Otherwise, stage 1 and 2A you can manage conservatively. Right? Right. Okay. Then coming back to this question, this patient, what is the stage of the disease in this patient? Is having intermittent claudication with claudication distance of 200 meters. It's either 2A or 2B. We can't differentiate clearly. Right? They're asking what is the most likely diagnosis. It's not acutely ischemic, it's chronic obstructive artery disease of the lower limb. Right? They haven't given the correct answer here. I took these questions from the medical students question banks. There are some errors. We'll correct as we go on. It's chronic limb ischemia, right? This clinical picture suggests of chronic limb ischemia. Then we move on to question number 49. A 60-year-old male with 30-pack history, smoking, 30-pack history of smoking, presented history of leg pain for last 6 months. Actually calculating pack years, right? Pain is worsened by walking and improves with rest. There's no pain at rest. On examination, BMI is high and decreased pulsation. Pulsation, you can't comment as decreased pulsation. No, it is either palpable or non-palpable, right? That is how you comment in your clinical examination. You can't say the pulses are diminished when you examine. Either you can feel pulses or you can't feel. If you can comment as character of the pulse, low volume or high volume. Decreased pulsation, it's wrong terminology. They might this low volume pulsation in dorsalis pedis on the left side. There is no gangrene or ulcer on both legs. Ankle brachial pressure index is 0.7. What is the most appropriate management? What is this ankle brachial pressure index? Anyone to answer this? What is ankle brachial pressure index? How do you measure that? It's a supplementary investigation to diagnose occlusive artery disease. How do you measure ankle brachial pressure index? Measure the blood pressure in the ankle. Then what do you do? There's someone has answered. How do you measure the blood pressure in the ankle? How do you do that? Is it just like your normal blood pressure measurement with sphygmomanometer? Do you use some other technique? Using ultrasound scan, not the ultrasound scan, right? What do you use? Yes, it's handheld Doppler. You use handheld Doppler, then occlude the ankle by blood pressure cuff and gradual release. And have you used handheld Doppler? You can get the detect the artery flow by sound waves, right? So you can check the pressure at the first point of this appearance of classical sound wave. You can do the same for brachial artery. You occlude, then gradually release the pressure while monitoring the distal flow by handheld Doppler. So is it posterior tibial that is used? You can use either posterior tibial or dorsalis pedis. That is not a big issue, right? Then you get the ratio. Usually, what is the normal value of the ankle brachial pressure index? Usually 0.9 to 1. Yes. What happens in critical limb occlusive artery disease? What happens? Yes. How do you correlate this ankle brachial pressure index values to this Fontaine classification? Claudicants and critical limb ischemia. How do it vary? Yes, 0.6 to 0.9 intermittent claudication. Less than 0.5 means critical limb ischemia, right? Yes, right. This patient ankle brachial pressure index is 0.7, right? That means patient doesn't have, and in the history also patient doesn't have pain at rest, no ulceration, or that patient doesn't have any evidence of tissue loss, right? It's a claudicant, heavy smoker, and claudication history for 6 months, no rest pain, and no tissue loss. So what is the most appropriate management in this patient? DSA, what do you do by DSA? That is mainly you do as a intervention, this therapeutic procedure, right? And Doppler ultrasound, you can't get anything. Refer to vascular surgery. Okay. And yes, answer should be smoking cessation, exercise, and follow in 3 months. That should be the best answer. Apart from when you take these 5 answers, that is the best answer. If it is non-disabling claudication, you can manage conservative. That is the best medical treatment. All these lifestyle modifications, omit smoking cessation, investigate for other risk factors, diabetes and dyslipidemia. If there are comorbidities, you should optimize. Then exercises, supervised exercises, right? Then reassess the patient. That should be the management. If the patient is having disabling claudication, claudication distance less than 200 meters, in that point you should intervene. Then you should do the imaging and assess the level of occlusion and plan the intervention, either open surgery or endoluminal, according to the what we add medications. Yes, definitely you should add statins and aspirin, right? Antiplatelets. That is the best medical therapy. And this answer that hasn't been included, but yes, exercises should be included, right? That is the best possible management option at this point to improve your claudication distance, and that is the action which develops collaterals. So patient will improve gradually, right? Smoking cessation, best medical therapy, and the exercises. If the patient is having Fontaine 2A degree of intermittent claudication. Here some parts of the question and the answers are missing, I think. Right? You should. Yes, we don't use metapropolis. They are not indicated for this, right? Usually statins and the antiplatelets. Right. That is that. You get the idea. Then right. Then we'll move on to do some MCQs on chronic limb ischemia, then move to other topic, right? This is nephrology. Right. Question number 57. A 35-year-old chronic smoker presents with ulceration of the tip of the right, second, third, and fourth toes. He gives history of recurrent migratory superficial febrillitis of the feet occurring a few years ago. Physical examination findings are remarkable for absent bilateral posterior tibial and dorsalis pedis pulses with palpable popliteal pulses. What is the single most step in his management? 35-year-old young patient, chronic smoker, ulceration of the tips of the right, second, third, and fourth toes, issue of recurrent migratory superficial febrillitis, and absent pedal pulses with palpable popliteal pulses. What is this clinical picture? What is the diagnosis in this patient? Yes, it's Burgess disease. What is Burgess disease? What happens in Burgess disease? No, I'm asking what is Burgess? This is Burgess disease. non-atherosclerotic inflammation. Yes. What are the vessels which are involved in Burgess disease? This is called thromboangiitis obliterans, right? This is up-to-date article. Burgess. It's an inflammatory vascular disease of unclear etiology that affects medium and small arteries, veins, and the nerves in the extremities for the upper limb and lower limbs, with rare involvement of visceral and cerebral vessels. Patients are predominantly young smokers who present with pain from distal extremity ischemia, ischemic digital ulcers, or digital gangrene. Disease is strongly associated with use of tobacco, drugs, and also with cannabis. That is the description, right? So it is characterized by segmental inflammatory thrombotic vessel occlusion. It is distinguished pathological from other forms of vasculitis by higher cellular inflammatory intraluminal thrombus, but no fibrinoid necrosis. The presence of an intact internal elastic membrane. So you can, if you take the biopsy, you can differentiate this inflammation in Burgess from other vasculitis and atherosclerotic reactions, right? This is basically diagnosis exclusion. Clinical picture will be more suggestive, but still you have to exclude other vasculitis and the other diseases which causes smaller vessel occlusion, right? This all the smoking is important pathogenesis. The specific etiologic mechanism remains unknown, right? So the evaluation of this thromboangiitis obliterans consists of history, examination, vascular evaluation, and laboratory examination. To serologically rule out other etiologies that can cause small and medium vessel occlusive artery diseases. The clinical diagnosis without need for biopsy can be established with following Collins criteria: age less than 50 years, current or recent history of tobacco use, distal extremity ischemia, typical arteriographic findings, right? What is this vascular imaging? We'll come to later, right? Then exclusion of autoimmune disease, right? Thrombophilia, diabetes, and proximal embolic stones. Those are again causes for this small vessel occlusions. So you should exclude those things. Then you can confirm there is more towards Burgess disease. Right? This biopsy of subcutaneous nodules of vein with superficial thrombolysis that shows the typical acute phase changes on history provides a definitive diagnosis. But we don't do biopsy always. It's basically clinical diagnosis after exclusion of other differential diagnosis. And most important factor is the smoking cessation, right? Then you can try this internal pneumatic compression. Calcium channel blockers may help to reduce vasospasm, right? Revascularization is usually not indicated because involved vessels are very small vessels, right? That is regarding Burgess, right? Right. That is again a topic which comes with occlusive artery disease. Then Right, we'll go to this question number 1. 65-year-old teacher developed arterial type intermittent claudication. That means it is occlusive artery disease, not the venous claudication or neurogenic claudication. That's what they have mentioned. Arterial type, this terminology is a bit wrong. Right? Involving both calf. Involving both calf on 500-meter walking. He can do all of his daily activities. He was on statin and aspirin. What is the most appropriate additional management option? This is both calf, that is bilateral intermittent claudication. Yes. It's again, what is the stage of the disease in this patient? According to Fontaine classification, yes, 2A. 2A, right? So you should not, you can manage conservatively without surgical intervention. So then comes your management, as we described earlier, based this. These are the management of options, right? Smoking cessation, lifestyle modification, optimize diabetes and dyslipidemia, antiplatelets, anti-hypertension, right? These are the treatment options. Then this exercise is the one which improves the muscle and endothelial cell function and improve collaterals, right? That is the basically the intervention. So poise exercises, right? Then question number 3, regarding the occlusive artery disease of the lower limb. Ankle brachial pressure index of 1 is abnormal. This is true false question. Can you answer this? Question number 3. What are the answers? First one is false, right? 0.9 to 1 is the normal range. Critical ischemic limb cannot be saved. That is false. That is the point where we intervene and save the limbs, right? It's a risk of limb loss. Patient might end up with amputation, but we can save to some percentage. Breast pain is best managed with anticoagulants. That is false. We usually don't give anticoagulants in chronic limb ischemia. We give antiplatelets in conservative management. And when you develop critical limb ischemia, breast pain or tissue loss, we should intervene. Right? You can't go with medical therapy. And anticoagulants, anyway, we don't give. Right? So C is false. Short segment occlusion is best treated with angioplasty. What do you say about D? Yes, D true, right? Short segment occlusions, you can best treat it with angioplasty. That is as a concept. Yes. Distal vascular disease is a contraindication for bypass surgery. What do you say about this E? What is the answer for 3E? What do you mean by distal vascular disease? Usually, right, if the involved arteries are microvascular, these small vessels like diabetic vasculopathy, right? Then you can't intervene. Otherwise, we can intervene. This terminology is a bit controversial, right? Distal vascular disease. I don't know what they meant. What you have to understand is this. microvascular occlusion. Conditions like diabetic foot, you can't do the bypasses because once this graft is longer and this inflow and outflows are not compatible, you can't get a successful conduit, working conduit. So in that case, you can't do bypass. Otherwise, you can do. This is terminology is a bit wrong, so we can't answer that, right? Right. Then question number 4. 46-year-old male has intermittent claudication of his right calf with claudication distance of 400 meters for last year, for throughout for 1 year duration. And he has attended surgical clinic. Which of the following is the best treatment option? Again, the same thing, right? Same thing will be question. Advice not to walk and rest, that is false. You should ask the patient to do the exercises, right? Ask the patient to walk till they get pain and walk through the pain. And with the optimal medical treatment and optimization of diabetes and dyslipidemia, you should advise about the exercises, right? 30 minutes per day, three times a week. You should continue at least for 6 months before terminating conservative management option. The graded exercise program, that is the best treatment option. Anticoagulant, that is we give antiplatelets, right? Anticoagulation means this heparin that is given in the acute limb ischemia and DVTs. Reassurance, we can't reassure and review because there's a pathology going on. Vascular reconstruction, not indicated in this stage. This is 2A. Right. Okay. Then Burgess syndrome commonly affects young males. What are the answers for question number 7? Question number 7. True. Commonly affect young males, true. More common in heavy smokers, true. Both upper and lower limbs are affected, true. Veins are affected, true. Proximal arteries are commonly, that is not commonly affected. Proximal arteries also affected, but commonly the distal arteries, right? So that's except E, others are true. Okay, good. Then question number 8. 56-year-old elderly male smoker present with intermittent claudication without any evidence of tissue loss. He does not have diabetes, hypertension, or dyslipidemia. What is the best management option? Again, same thing, no? Stop smoking, yes. Antiplatelets, statins, and the walking exercises. Answer is C. Right. So you can just now see how they make questions to check the knowledge on Fontaine classification and your pathophysiology, right? Right. Then question number 9. A patient waiting for femorodistal bypass surgery. Patient was waiting for femorodistal bypass. It was done at the proximal tibial artery. For a occlusive arteries patient, they have done a femdistal bypass, right? From the femoral artery by conduit as anastomosis to common femoral artery and to the tibial artery. What is the structure great risk to get damage when mobilizing tibial artery? You should, the anastomose to anterior tibial artery. Usually anterior, we anastomose to anterior tibial. We assess the outflow and select a vessel, right? We assume they have done the anastomosis. Yes, sorry. Assume they have done the anastomosis to the anterior tibial artery. What is the structure which can damage when mobilizing the artery? What are your answers? Hmm? Usually, with anterior tibial artery, this deep peroneal artery goes, right? Common peroneal artery comes and divides in superficial and deep peroneal nerves. And with the anterior tibial artery goes the deep peroneal nerve. So, bypass. What arteries is involved in bypass of this patient? Right. Femdistal bypass. They have done a femdistal bypass. Volume. Get an image. You can see this image now. Here comes this common femoral. Then it divides into profunda femoral and superficial femoral artery. Right? Superficial femoral artery comes and here divides into anterior and posterior tibial artery. Right? This is the posterior view. This is the popliteal fossa. This common superficial femoral becomes popliteal artery. Then this is the trifurcation of the popliteal artery. Right? It divides in posterior tibial and the anterior tibial. From the posterior tibial gives the peroneal artery. Right? This is called trifurcation of the popliteal artery. So this is the anterior tibial artery. They have done the anastomosis from the superficial femoral, common femoral. The occlusion should be here from involving superficial femoral artery and popliteal artery. So they have done the anastomo bypass surgery, anastomosing the graft to the common femoral and then the anterior tibia. Okay, is it clear? So with the anterior tibial artery, this deep peroneal nerve complex, that is the nerve which can be damaged. That is the anatomy. This is how they run, right? This common peroneal nerve divides into deep and superficial peroneal nerves. Deep peroneal nerve runs with the anterior tibial artery. This is the nerve which can be damaged when you mobilize the anterior tibial artery. Okay, is it clear? Right. Then that is that. Question number 11. So answer is yes, either common peroneal or, but the correct answer is deep peroneal. They are given the answer. So some students have made this question by remembering there are some errors, right? But the questions are, the pattern of questions will be same in your exam. So you get the idea, right? Then that's it. Question number 11, 45-year-old man who was a chronic smoker has an ulcer on the top. There is no dorsalis pedis pulse. Pedal pulse is absent. What is the best option in the management? What is the answer for this? And what is the stage of the disease? What is the answer? What is chronic smoker, ulcer on the top, absent pedal pulses? What is the diagnosis? Anyone? Peripheral vascular disease due to smoking, yes. What is the stage? This is a it's critical limb ischemia, Fontaine. Fontaine classification stage 4, grade 4 disease. So how do you manage this patient? Can you manage conservatively with medical treatment and exercises? And there's a wound, right? There's a confusion. First thing, right, is there's ischemic ulcer. If the patient doesn't have a septic limb, you should not touch the wound, right? First, you should establish circulation. That's after only establishing the arterial supply, wound tend to start healing. Otherwise, if you do the wound debridement, that won't help you to improve the wound healing, right? First, to establish the arterial flow by revascularization, unless patient is having progressive infection, septically, right? Septic ischemic limb is worse than the non-septic ischemic limb. If the limb is septic with ischemia, then you have to do the minimum wound debridement and get the infection out. Otherwise, you do the revascularization, then do the wound debridement, right? That should be the rationale, because due to get a wound healing, there should be adequate arterial flow. Nutrition and hemoglobin should be carried to the wound bed to get the tissue healing. So you do the revascularization, then do the wound debridement if it is needed. They haven't described about the ulcer pattern and the whether it is infected or not. Wound of the osam, I think there's errors, right? I don't know what they have mentioned. The rationale is you do the revascularization first, then do the wound debridement if it is needed. Otherwise, usually with the revascularization, wound start healing. You can do minimum wound debridement if there are granulation, if there are sloughs and the necrotic tissue. Otherwise, you may not need to do the wound debridement, right? That is the rationale. So you can take C as the best answer, no? Revascularization, then do the wound debridement. Right. Question number 13. 40-year-old patient comes with intermittent claudication and the claudication distance is 40 meters. What is the best management option? Again, what is the stage of the disease? And what is the answer? Yes, it's disabling claudication. What is the answer for this? What is the answer for the question? Yes. It should be intervened, right? Disabling claudication. Right. Okay. What is the difference between excision of motor and motor? I don't know. That is, I think they have made wrong steps, right? I've taken from this question from Colombo medical faculty question bank. Right. Okay. Then clinical features associated with chronic occlusive arterial disease of the lower limb. Clinical features associated with chronic occlusive arterial disease. Can you answer the question number 14? Intermittent claudication? Yes. Also the median malleolus? It's usually venous ulcers, right? In the artery, where do you get this ischemic ulcers, arterial ulcers? Between web spaces and toes and dorsum of the foot, right? Then rest pain, again a feature. Impotence, it is important. Impotence. You get impotence in which condition? What is the syndrome? You get this absent distal pulses, intermittent claudication, and impotence. What is that syndrome called? Yes, Rerich syndrome. Yes. That is again a feature of peripheral vascular disease of the lower limb. Then shiny skin. Yes, again due to this atrophied ischemic skin. Right. Okay. Then question number 15. 55-year-old male present with intermittent claudication. Claudication distance is 100 meters. He's non-ischemic heart disease patient on medication. What is the best initial investigation to this patient? So, what is the Fontaine class? What is the severity of the disease? Fontaine classification stage 2B. Yes. Okay. Then stage 2B means disabling claudication means you have to intervene. That is the point where you should do the imaging. If you plan for an intervention, then you should do the imaging and assess the severity of occlusion and the anatomy of the vascular tree. Then you can plan your surgical intervention. So what is the initial investigation? Yes, it should be arterial duplex, right? Arterial duplex study of the lower limb. Right. Usually below infrainguinal disease, arterial duplex will be adequate. If it is involving the proximal arterial tree, aorta, ilia, then comes this CT angiogram, right? Otherwise, most of the time, arterial duplex will be adequate to plan your intervention. Right. That's it. So, answer will be C. Question number 20. A 40-year-old patient comes with intermittent claudication and claudication distance 400 meters. What is the best management option? Again, same question, no? Answer A. Right. All right. Clinical features associated with the same question. We did this. 22 also same one, no? Regarding Burgess disease, again same one. Right. Question number 25. 50-year-old smoker who is having intermittent claudication found to have superficial femoral artery occlusion. Right? He's having superficial femoral artery occlusion. Patient is having intermittent claudication. They haven't mentioned whether it is disabling claudication or non-disabling. Ankle brachial pressure index is less than 0.9. That's true or false. True, yes. Graded exercise is not beneficial. That is false. Graded exercise is anyway beneficial for any disease state, right? That will improve the collaterals. Low dose aspirin improves the claudication distance. What do you say? Claudication distance, it doesn't improve the claudication distance, right? It reduces the progression of the disease, but for you to get improvement in claudication distance, that is the exercise. You should advise the patient to exercises, right? So C should be false. Should transfer to general hospital for early bypass. You can't say like that because still there is no indication for intervene. Right? That is also false. Aortobiofemoral graft surgery is treatment of no. If you are going to do a bypass, if the patient is having disability, assume patient is having disabling claudication or critical limb ischemia with superficial femoral artery occlusion. But the rest of the artery tree is all right. How? From which level to which level you do the bypass? Any suggestion? Any idea? Not the iliofemoral. There is a superficial femoral artery occlusion. Your femoral, common femoral artery pulsations are palpable. Popliteal is absent. Occlusion, you do the artery represent, there is an occlusion at the superficial femoral artery. Good run off popliteal downwards. Where should you do the anastomosis? Graft anastomosis from. Yes, it should be common femoral to popliteal. Fem-pop bypass, femoral popliteal bypass, right? So you avoid the occlusion and get the conduit from good run into run out. Good inflow to good outflow. This vasculature. Right. That is regarding question number 25. Regarding atheroma of aortoiliac segment. Regarding atheroma of aortoiliac segment, commonly present with impotence. What do you say? Question number 31. Yes, it's not common. Can present with impotence, but it's not the common, right? Intermittent claudication occurs only in gluteal segment. What do you say about this? B. Why it is false? Because it's obvious with a more proximal occlusion, entire when there is an exertion, all the musculature will be ischemic. So you can't get pain only in gluteal segment. The rest of the musculature will be all ischemic. So you get pain in the proximal occlusion. What happens is, apart from the calf pain, you get the gluteal pain as well. That is what happens with a more proximal occlusion, right? Why impotence false? It's false because it's not the commonest presentation in the aortoiliac. In the aortoiliac segment, you can get the impotence in Ricci syndrome, but it's not the commonest presentation, right? Right. Then intermittent claudication pain does not occur in calf. That is false. No, again false. Numbness is not a feature. What do you say for this? Usually chronic limb ischemia, numbness and the numbness and the paresthesia and the paralysis is rare, but we can't say it's not a feature, not common in chronic, but still it can occur. We can't. Yes, in acute limb ischemia, paresthesia is common. Still, it can be present due to ischemia, right? So numbness is not a feature. We can't say it is true. It's false. It can be a feature. Then endarterectomy is better than bypass. What do you say for this? 31E. It's again false. We don't do endarterectomy for this aortoiliac segment, either endoliminal intervention or bypasses, right? Okay. Then 33 regarding rest pain. Worse in the thigh due to larger muscle bulk. Yes, it's usually rest pain forefoot, right? Because that is the most distal part, no? So that will be the most part which gets ischemia at rest. First part of the limb which get pain at rest due to critical limb disease. So at the initial presentation of the rest pain, patient will be having forefoot pain. If they get rest pain at the thigh level, that means it should be severe occlusion. Limb should be dead by then, right? So it's ischemic rest pain occurs in forefoot. It is most commonly due to small vessel disease in the foot. What do you say for this? That's again false, right? It's not due to small. If it is small vessel disease, they won't get this rest pain, no? Right? Rest pain occurs due to severe occlusion, and they can't get the adequate blood supply even at rest to maintain basal metabolic rate. Rest pain not suitable for surgical bypass. What is the answer for 33C? It's false because that is the point where you should intervene. Right? Rest pain is an indication for surgical bypass or surgical intervention. So it's false. Lumbar sympathectomy is a treatment option. What do you say for that? D. What is the answer for D? Yes, it's false, right? It's not neuropathic pain. There's an obvious etiology, that is the compromised blood supply. You should get the adequate perfusion to relieve the ischemic pain. You can't get just relieve the symptoms without treating the etiology, right? So it's false. Critical ischemic limb cannot be saved. Again, it's false, right? E also false. Right. That is question number 33. Question number 34. Features differentiating arterial intermittent claudication from venous claudication. How do you differentiate intermittent arterial claudication from venous claudication? In venous claudication, what happens? Do they get pain on standing? In the arterial claudication, they won't get pain at rest, right? So no pain on standing is true. But in the venous claudication, with standing, they get venous hypertension and pain, right? Cramping type pain. Cramping type pain usually occurs in in venous, it's dull pain, yes, cramping type pain, aching type pain in internal claudication. Then relieved by raising the leg. Yes, usually venous claudication will be relieved by elevation because that will facilitate the venous flow. In the arterial occlusion, elevation will increase the pain if patient is having severe ischemia. In a state like critical limb ischemia, they get severe pain on elevation, right? And again, in arterial intermittent claudication, it is reproducible. Yes, it arises with some degree of exertion, then complete relief by rest, again recurs with the same distance of exertion. So false, true, true, false, and true. Yes, that is the answer. Those are the answers for 34. 37. Which of the following can be used in arterial disease management? 37. Quickly answer. Answer question number 37. Hospital orders, exercises, diet control. Do you use streptokinase in arterial disease management? Thrombolysis you don't do, no? Yes. Apart from D, other all are true. D is false. Right. Okay. Question number 41. Regarding intermittent claudication, smoking reduces the claudication distance. Can you answer question number 41? We'll touch acute heart disease after finishing this, right? Smoking doesn't reduce the claudication distance. It will reduce the progression, right? What do you say? Graded exercise improve collateral circulation. True. Arteriography is essential. False. Unless you plan for intervention, you don't have to do the imaging. Artery duplex done in all patients, that is again false. Unless you plan to intervention, you don't do imaging. Can be managed conservatively. Yes, you don't need surgical intervention always, right? So if false, D true, C and D false, E true. Right. Answer for A. Smoking reduces claudication resistance is false. It doesn't reduce the claudication distance. There's a already disease has occurred. So you to get reduction of claudication distance, you should develop collaterals, right? Because occlusion will be there, you can prevent the progression by cessation of smoking. Question of 42 regarding peripheral vascular disease, all the stage of tissue loss, nothing can be done. That is again false, right? Bypass is always better than angioplasty. What do you say for that? Question 42B. Bypass is always better than angioplasty. Why do you say? What do you say about that? It's false because suprainguinal diseases, endovascular intervention is better, right? Below the inguinal ligament. Infrainguinal diseases, when you compare the long-term outcome, bypass surgery is better. Again, this whether you do angioplasty or bypass, that depends on the type of occlusion. There is multi-segmental, right, and level of occlusion. So you have to compare many factors with angioplasty. What do you say for that? Even for infrainguinal diseases, short-term outcome is equal when it comes to angioplasty and the bypass surgery, right? More or less equal. So it is again false. Aspirin increases the claudication distance. What do you say about 42D? Yes, it's false. Proper foot care is essential. 42E. That is true. Yes, to avoid trauma and ulceration, right? Short-term outcome means um, the early, do you know about Basil trial? They compare the outcomes within first 2 years and after 2 years. Maybe they may have a question on this. They have something, I think. I assume that is the fact they are checking, right? Outcome within the first 2 years and afterwards. Long-term outcome means after 2 years, right? In your questions, they will elaborate properly. This collected MCQs, they have missed some parts in the question. Just read on Basil trial. There's a trial called Basil trial, right? Right. Ischemic ulcers. Question number 45. Those associated neuropathy may be painless. What is the answer? Suprainguinal arterial occlusions, treatment, either endoluminal intervention or bypasses, right? That depends on the level of occlusion and how long is involved segment. Ischemic ulcers are common in patients with intermittent claudication. Yes. Should be, can be treated by bed rest and elevation. Again, false. If there is ischemia, you should correct the ischemia. That means you should revasculate. Revascularize the wound bed. Ischemic ulcers are definite indication for revascularization. Yes. Are treated by local excision and ischemic ulcer. That is false. First, you revascularize, then wound will start to heal. Then you can intervene accordingly, right? Right. Those are the questions on chronic limb ischemia. There were a few questions in recent. This is this year paper. Question 49. A 65-year-old retired teaches intermittent arterial claudication of both calves on walking for 500 meters. He is able to perform his daily activities. He is on aspirin and aspirin. What is the most appropriate adjunct for his management? What is the answer for this question? Yes, answer is E, walking exercise. This paper is this is a March paper, right? Again, December paper. Question number 16. 50-year-old retired school teacher with history of smoking for 20 years presented calf claudication after walking 200 meters. On examination, they have absent popliteal and wheel pulses. Can you answer this question quickly? Arterial imaging is needed to decide further management. Expected ankle blood pressure index is 0.3 to 0.5. B. False. Yes, it's critical limb ischemia level. Yes, here he is having intermittent claudication with possible disabling, right? Disabling 200 meters. Revascularization is needed. True if it is 2B, yes. Risk of cardiovascular event is 2 to 3 times higher than normal. Again, it's true. Caused by occlusion of superficial femoral artery. Just absent popliteal and downwards, no? Yes. Right. Then So, right. We just go through this note quickly. With regard to chronic limb ischemia, it is a continuum from asymptomatic atherosclerotic peripheral artery disease through intermittent claudication to the limb-threatening critical limb ischemia. We have talked about that. Risk factors, they are modifiable and non-modifiable. Smoking, diabetes, hypertension, dyslipidemia, and hyperglycemic status, age, gender, and ethnicity. Right? Mainly the atherosclerotic disease, which leads to occlusion. If the patient is younger, then you have to think about other DDs, thrombophilia status. If the patient is a heavy smoker, should think about Burgers. Athletic patients, we should think about popliteal artery entrapment, iliac artery endofibrosis. Those are rare phenomena, right? Then differential diagnosis. Vascular causes that actually produce chronic limb ischemia, and non-vascular causes that mean chronic limb ischemia, osteoarthritis, neurogenic and venous claudication. Right? Due to this atherosclerosis, everywhere can be affected. If it is affected by, if the lower limb is affected by atherosclerosis, there will be claudication, rest pain, and gangrene. If it is affected, if brain vasculature is affected, patient develop TIAs and strokes. If the myocardial vasculature is affected by atherosclerosis, patient will develop angina or MI. And if the kidney vasculature is affected, patient will develop renal failure or hypertension. If the intestinal vasculature is get affected, they will get mesenteric angina. Right? Intermittent claudication is cramp-like pain felt in the muscles brought on by walking, and it's felt most in the calf because of 70% of cases are superficial femoral artery affected, right? 30% aortoiliac diseases, pain in thigh or buttock, but again, calf is also involved, right? Not only the thigh. Diabetics don't have intermittent claudication most of the time due to neuropathy, yes. Discuss those. And neurogenic claudication. Standing walking triggers, sitting down may relieve. We have described critical limb ischemia and rest pain. And classification, investigations. This is ABPI values, 0.91 normal, less than 0.9 some degree of arterial occlusion, less than 0.5 rest pain, less than 0.3 median necrosis, more than 1 means calcified, incompressible arteries. Measure toe brachial pressure index. If you can't measure this ankle pressure due to arteriosclerosis, right? Then you have Doppler assessment, this triphasic, biphasic, monophasic appearance depending on occlusion. Important interpretations of Doppler, inflow and outflow, right? Outflow normal artery pulsation triphasic, mild stenosis biphasic. If there's severe stenosis, that is monophasic. This is this triphasic appearance, right? Antegrade systole, retrograde early diastole, and antegrade late diastole. This is triphasic appearance. This is biphasic and this is monophasic. Then DSS-CT angiogram, management, non-pharmacological, pharmacological management. Then specific management, supervised regular exercises within the disability. Then silososol, critical limb ischemia. You should do the surgical management. consider management only for patient who is not for surgical intervention. Right? This is Basil trial. In truncated diseases with life expectancy more than 2 years, bypass is recommended over endovascular treatment. And that is what I taught. This conduit bypass graft can be venous graft, natural graft, or synthetic graft, right? Okay, that's that. Right. Then we'll move on to acute limb ischemia, no? Okay, question number 56. 55-year-old man presenting with sudden onset severe pain in his left foot and calf for 6 hours. There are absent pulses below his left knee, but a palpable femoral pulsation. Which of the following best differentiate atherosclerotic obstruction from embolic obstruction? Can you answer this? Question number 56. Hello? Question number 56. Can you answer? Yes, what is the answer first? Yes. YE. Answer is hair loss of the foot. Yes. YE. Yes, it's like a acute and chronic limb ischemia. No? There is ongoing occlusive arterial disease in the lower limb vasculature, and suddenly there will be plaque rupture and acute thrombus formation. Due to that, there will be a acute sudden occlusion of the vasculature in a already compromised vascular tree. So, due to chronic limb ischemia in the limb, there will be ischemic changes like this hair loss, atrophied musculature, right? And due to this collateral development as adaptation to chronic limb ischemia, in this sort of a clinical picture, this acute limb ischemia won't be severe as you encounter in virgin vascular bed, right? If it is embolus in a normal vascular tree, this acute limb ischemia is so severe, very severe than this, because there won't be collateral circulation, much collateral circulation to overcome the occlusion. Here, due to chronic limb ischemia, there will be already formed collaterals that will compensate the acute occlusion up to some degree. So that is that. And this cold limb paresthesia, inability, the paralysis, all are common for acute limb ischemia. So even in embolism and plaque rupture, irrespective of the etiology, these 6 P's will be present. This chronic limb ischemia, features of chronic limb ischemia only present in atherosclerotic obstruction, atherosclerotic in a patient who is already having atherosclerotic disease in the lower limb vasculature. In this sort of patient, if you feel the pulses of the other limb pulses will also not palpable, right? Because atherosclerosis is diffuse, it's systemic disease, no? Due to dyslipidemia, most of the vasculature will be affected. So most probably other limb also will have features of chronic limb ischemia. Usual, right? That's it. Then question number 51. 75-year-old man presented sudden onset right-sided leg pain and paresthesia. On examination, distal pulses are absent and limb is cold. Neurologic examination is normal. Clinical diagnosis, right lower limb embolus. Clinical diagnosis should be right lower limb acute limb ischemia, right? Embolus, that is etiology, could be thrombosis or embolism. Patient was given heparin and emergency embolectomy was done. What will you do next? What is the answer for question number 51? Due to embolism. Okay, in this of patient, this clinical picture can be due to embolism or thrombosis, right? Then you do the embolectomy and relieve the acute occlusion and restore the blood flow. Then how do you proceed? How do you investigate this patient further? If you suspect embolism as an etiology, what you should do? What you should do? You should find the source of the embolism. Not only ECG. Yes, you should do ECG to find the if there are any arrhythmias at atrial fibrillations like that. Then you should do 2D echo. Yes. Are there any ventricular dilatations, cardiac embolus? Are there any source of embolism due to ventricular aneurysms, right? Then you should look for aortic aneurysms as well. Those also will be sources of embolism, right? Those thrombus which form in the any area of turbulent flow in the vasculature will shoot out and obstruct in the lower limb vasculature. If it is going to cerebral vasculature, again, patient will develop cerebrovascular accidents. If it comes to lower limb vasculature, they will develop acute limb ischemia, right? So you should find the source of the source where the thrombus has formed and where this embolus has come from, right? So you should find the source. If it is unprovoked, if you can't find source, that is a bit difficult clinical scenario. Anyway, you should continue long warfarin, right? So you should find the etiology, and if it is correctable, you can. If it is aortic aneurysm, you can repair it. And if it is like arrhythmia, then you should treat the arrhythmia as same as you should start anticoagulation. Patient should be started on warfarin. So answer should be C. Right. What's that? Question 50. What is the next best step in the management of a patient present with acute limb ischemia? What is the answer for question number 50? Surgical embolectomy, angioplasty, correct risk factors and conservative management, urgent angiogram, hourly monitoring of the toe saturation. Why D? What is the best step in the management? Acute limb ischemia. Yes, it should be a surgical embolectomy. You can't do imaging in a this Rutherford classification 2B, right? So best option is the embolectomy, right? Look at two imaging this viable limbs and margin threatened limbs. If it is imminently threatened, that is if it is Rutherford classification 2B, you can't wait for imaging, you should do the embolectomy straight away. So the best treatment option should be A, surgical embolectomy. Right. Then go upwards. Question number 43. Acute arterial occlusion. Fixed skin staining is an early sign. What do you say? This skin mottling. It's a late sign, right? Should be treated conservatively if the site of the occlusion is above the inguinal ligament. There's nothing like that. You go according to the Rutherford classification, right? And you can't, if it is about occlusion is more proximal, that means occlusion will be more severe, right? Demands the urgent use of vasodilator drugs in acute arterial occlusion. What is the management? If the patient, you get a patient with acute limb ischemia to the emergency department, how do you start the management? Straight away you start anticoagulation. Yes, as this global heparin action is reversible and you can reverse by drugs, you start heparin. 80 milligram per kg bolus followed by 18 milligram per kg infusion, right? That is anticoagulation. No point of giving vasodilators, right? Right. Then demand, that is false of acute of a limb is usually painless due to anoxic damage producing the peripheral nerves. Again, it's false. It will be very painful, no? It is ischemia. May produce irreversible muscle necrosis after 6 hours. Yes, that is true. Okay, right. Question number 35, acute arterial occlusion. Thromboembolism is the commonest cause. How do you answer this? Yes, it is the embolism, which is commonest, right? Has less dramatic effects on those with underlying occlusive diseases. In a chronic ischemic limb, if there is a acute arterial occlusion, that is less dramatic when compared to virgin vascular bed, right? Because more often in patient with sinus rhythm, that is false. Atrial fibrillation may be a causative factor. Again, yes, it's a factor for thromboembolism. Thrombus is seen in aortic bifurcation. What do you mean by that? There's saddle embolism. So, rare possibility, right? What is your answer for E? In acute limb ischemia, it's false, right? Yes, thromboembolism is the commonest cause. For what is the answer for 35A? What is the commonest cause for acute limb ischemia? 1. 2. 3. 4. 5. 6. 7. 8. 9. 10. 11. 12. 13. 14. 15. 16. 17. 18. 19. 20. 21. 22. 23. 24. 25. 26. 27. 28. 29. 30. 31. 32. 33. 34. 35. 36. 37. 38. 39. 40. 41. 42. 43. 44. 45. 46. 47. 48. 49. 50. 51. 52. 53. 54. 55. 56. 57. 58. 59. 60. 61. 62. 63. 64. 65. 66. 67. 68. 69. 70. 71. 72. 73. 74. 75. 76. 77. 78. 79. 80. 81. 82. 83. 84. 85. 86. 87. 88. 89. 90. 91. 92. 93. 94. 95. 96. 97. 98. 99. 100. 101. 102. 103. 104. 105. 106. 107. 108. 109. 110. 111. 112. 113. 114. 115. 116. 117. 118. 119. 120. 121. The two pathology are thrombosis and embolism. Correlates. If I had true, yes. Embolism cornerstones. Question number 23. You are asked to see a 67-year-old woman admitted severe limb ischemia. Your senior colleague asks you to examine the patient and report your findings. What are the two most likely clinical features that suggest the patient has severe limb? Assume this is acute limb ischemia. What are the clinical features that suggest the patient has having severe limb ischemia? What is the answer for 23? What is the answer for 23? If the muscles get ischemic, that is the point where you get paralysis, right? That is the bit of a severe stage, right? In acute limb ischemia. Initially, you get pulselessness, then ischemic pain, then comes this paresthesia, paralysis, perishing cold, right? So the paresthesia and paralysis is a when muscles get paralysis, that means muscles are severely ischemic. That is a bit of severe ischemic state. Right? If the patient comes with acute limb ischemia, if the patient can't move the toes and the ankle, that means patient is having impending the very severe ischemia. Patient may lose the limb. Right? So the answer should be B. So paralysis happens late to no, it's in the acute limb ischemia. First thing is the cut down of the pulse because there will be occlusion. It's not like your compartments. First thing is the cut down of the blood supply by occlusion of the artery. The first sign will be pulselessness. Then it becomes the develops the features of ischemia and necrosis. Severe pain, perishing cold, pallor, paresthesia, and paralysis. Right? Okay. Did you get that, Kiribaba? Pulselessness. It's not late. It's the first sign you get in acute limb ischemia. Right. Okay. Answer is B. Answer is B. Yes, paresthesia and paralysis. Yes. Then again, same thing in question number 19. Right. We'll just go through the This acute limb ischemia. Acute limb ischemia definition is sudden decrease in limb perfusion. That means the viability of the limb. Right? Causes thrombosis and embolism. Peripheral artery disease, patients having plaque rupture, thrombosis on top of the atherosclerotic plaque. Right? And embolism due to atrial fibrillation, atherosclerotic emboli, rheumatic heart disease, artery. Then, due to arterial dissection, also people can develop acute limb ischemia. With regard to clinical assessment, assess the patient to find out 4 principal factors. The acute limb ischemia due to embolism or thrombus on an atherosclerotic plaque. Degree of viability of limb according to the Rutherford classification. Level of obstruction, risk of developing compartment syndrome. Right? Then in examination, acute limb ischemia has 6 P's: pain, paresthesia, perishing cold, pallor, paralysis, and pulseless limb. This chronological order that we'll see in the comparison will not be seen here. First to go will be the pulses. But because of that, he will develop other P's, 5 P's, right? Assess the degree of viability depending on sensory impairment, motor impairment, arterial, venous, Doppler pulses. The level of obstruction by the affected pulse level. You can feel the pulse and decide which level is the occlusion is, right? If there's occlusion at femoral level, below the downwards, you won't feel pulses. If it is at the appropriate level, femoral pulses will be palpable, right? Opposite limb assessment. If pulses in the opposite limb are normal and limb appears to be healthy, more likely to be an embolus, right? That's what I said. If the limb has opposite limb also has trophic changes, diminished pulses, more likely to be thrombus on a plaque. Chronic should be atherosclerotic disease already on the limb, both bilateral limbs, and there's a possibility of plaque rupture, right? Then this Rutherford classification, 3 stages. Viable limb is stage 1, irreversible dead limb is stage 3. 2 is the threatened limb, A is marginally threatened, 2B is immediately threatened, right? The clinical findings in irreversibly damaged non-viable limb, major tissue loss or permanent nerve damage, profound sensory loss, profound paralysis, patient limb will be RIGO. Doppler signals for arterial venous flow will be inaudible. In viable limb, there won't be any sensory loss or muscle weakness, arterial and venous Doppler flows will be audible. In marginally threatened limb, there will be minimal sensory loss, right? Arterial flow is often inaudible. Right? In immediately threatened limb, there will be a sensory loss and patient will have pain. There will be mild motor weakness and arterial flow will be inaudible almost always. Right? That's how you classify the 3 stages of acute limb ischemia. Immediately following clinical assessment, if the patient is having acute limb ischemia, give a start dose of heparin, 80 mg per kg. Start the patient on hourly drip of 18 mg per kg. Heparin maintains the circulation by keeping collaterals patent. It also promotes throtholysis because it counteracts the clotting mechanism. If the assessment is Rutherford 3, that is your only option is to amputate. If it is Rutherford 2B, immediately requires revascularization without imaging. If the limb viability is uncertain, you should do a fasciotomy and assess the viability before reperfuse. Otherwise, if your reperfuse is non-viable or severely ischemic limb, patient will develop ischemia reperfusion syndrome. That is also again life-threatening. If you are treating limb-threatening condition and if patient develops life-threatening complication, that is more disastrous. But 1 or 2A limb imaging prior to revascularization is the principle, right? Either arterial duplex or CT angiogram. So, if the patient comes with Rutherford 1 or 2A, this situation most likely be due to atherosclerosis, unlikely be due to embolus. If it is embolus, patient comes with most of the time 2B or 3 because it is more severe ischemia. Picture is more severe in embolism. Situation is usually due to thrombus, right? Then there is a catheter-guided thrombolysis. There's a place of catheter-guided thrombolysis or surgical option, endarterectomy or arterial bypass on an urgent basis, right? And that is for one or 2A, right? Anticoagulation given lifelong. No, if it is embolism, if it is due to embolism, you should give, right? If it is due to plaque rupture, atherosclerosis, no point of giving anticoagulation. You treat the atherosclerosis disease with an antiplatelets, right? If it is due to embolism and there's a risk of recurrence of thromboembolism, you give anticoagulants, right? If it is the thrombosis, plaque rupture, then you should decide on catheter-guided thrombolysis and endarterectomy or artery bypass. If it's the embolism, then you straight away go for embolectomy stage 2B. Then, if you can't find the focus of embolism, do we do prophylactic IVC filter? IVC filter you should put in DVTs. Here, what happens is embolism, thrombosis in arterial tree with shoot ups along the arteries. You put IVC filters to prevent venous thromboembolism, right? Venous flood dissemination. And patient can develop these complications after reperfusion, ischemia reperfusion syndrome, and compartment syndrome, right? This is follow-up after acute limb ischemia management, cardiac assessment, 2D echo ECG, CT aorta to exclude aortic artery aneurysm, popliteal femoral aneurysms, thrombophilia screen. 3 to 6 months anticoagulation for those with proven thrombotic or embolic acute limb ischemia, right? So if it is thromboembolism, 3 to 6 months of anticoagulation, not the life. And if there's a indication for lifelong embolism like symptomatic AF or untreated arrhythmia, uncorrected, then you should continue anticoagulation lifetime. Right. That is the picture of acute limb ischemia. Right. According to this description, actually, most of the time we can salvage the limbs. So it should be commonest presentation of acute limb should be due to plaque rupture, not due to embolism. So what we have taken, the commonest presentation. We took it as true, commonest presentation to embolism, but I think it should be false, right? I'll check with that. This if it is due to embolism, most of the time patient comes with 2B or 3. But we can in acute limb ischemia, I'm not sure, but we can save Majority of the limbs, no, in acute limb ischemia. So it should be, I think, plaque rupture rather than embolism, even in acute limb ischemia. I'll check with that and let you all know, right? Kyo, did you get my answer? If we no point of putting prophylactic if you want to diagnose a deep vein thrombosis. IV filter prevent the embolism from deep vein thrombosis, right? Not from the systemic artery flow. It won't prevent embolism from shoot up from aortic aneurysm. It won't prevent, right? You keep the filter in vena cava. Right. That's it. Then we'll move on to venous diseases, no? Right. Question number 2. 28-year-old woman presents with saphenofemoral and long saphenous reflux, causes varicose veins and pigmentation in the gate area. What is the most appropriate management? What is the answer for question number 2? Yes, most of the people have answered question C as the answer: saphenofemoral ligation, stripping, and stub version. Yes, and once one or two has answered as B, saphenofemoral ligation, and it should be stripping, right? If you do the open surgery, should be ligation, stripping, and stub below knee, right? So best option out of this 5 answers will be C, right? Stub evaluation means you make a stub by your number and blade and evaluates this superficial veins, right? You mark the below knee dilated veins, tortuous veins on standing position. Then you, after you do the saphenofemoral ligation and stripping, below knee veins, you make a stub and you just drag it out and keep the direct pressure till bleeding settles. That's how you address below knee tortuous veins, right? You make a stub and towards the veins, right? I want to see in this varicose vein surgeries. When you do the internship, you will see how you decide whether to go ahead with sclerotherapy or stripping. Yes, stripping is open sclerotherapy is to give this sclerosants to the veins and make the veins, the endothelium of the veins, irritative, and that will cause fibrosis, right? And that will occlude the dilated veins. And in open surgery, we dislocate the superficial venous system from the deep venous system, right? So, what is better, sclerotherapy or open surgery? We can't compare. Still, these studies are going on. Some surgeons use sclerotherapy as the initial treatment modality, but recurrent rates, according to the current evidences, recurrent rates are higher in sclerotherapy when we compare with the open surgery. But Endovenous laser ablation and radio ablation are equally efficient as the open surgery. So recurrence rates are similar, right? So all are possible options. It depends. It depends on your clinical judgment and your favoration, right? We'll touch on these topics when we discuss the theory part, right? How do you exclude E? Because there's a long saphenous femoral reflux, no? Stabilization won't address that part. So you can't take E, right? So best option should be B, right? C, right? Saphenofemoral ligation and stripping and this stabilization or sclerotherapy to address below varicosities, right? Question number 5. 25-year-old female working at a garment factory present with ulcer on manual region for 3 months. She has varicose veins and saphenofemoral reflux. Management includes. Can you all answer this question number 5? This is true, false. Question. Question number 5. How to exclude D in question number 2? Yes, sclerosant, still the recurrence rates are higher in sclerotherapy. When you compare this open surgery and sclerotherapy, recurrence rates of sclerotherapy is higher. So best option should be open surgery still for the time being. That is the best option. But if you have given endovenous laser ablation or radio ablation, that can be taken as true, as same as your open surgery. There is no difference, right? Most of the time, that is the best. Minimal invasive surgeries are best. No? We choose endovenous laser ablation, radio ablation as the first line treatment. That is regarding question number 2. Question number 5. True, false, true. Yes. No point of taking biopsy as this is a venous ulcer. It's 3 months. Blood sugar should be checked to exclude diabetes. Refer to duplex scan as this in the venous disease also. If you plan for intervention, you should do the imaging, right? So the patient is symptomatic and you should plan for a surgical intervention, you should do the imaging. And compression again works for facilitates the venous drainage. Ligation of long saphenous vein at SFJ again is definitive treatment for this condition. Do we do compression when there's an ulcer? Yes, still we can do. It will facilitate the venous drainage. Some older practices, we put the 3-layer bandage weekly till ulcer gets healed. Then you do the surgery. But it's now out of practice. If there's even if there's an ulcer, infective ulcer, we address the venous hypertension by doing surgery and remove the venous hypertension. Then ulcer will quickly heal. Otherwise, with the dressing only compressive dressings, it will take longer time to heal the ulcer and patient will be exhausted. So current practices, even with ulcer, you do the surgery. There's a risk of infection, of the surgical site infection. Still, you do the surgery and remove the etiology for the ulceration. Then ulcer starts healing. Right? That's that. Question number 6. 25 garment worker comes with non-healing ulcer on examination, suffering from incompetence, varicose veins around the knees were noted. What are the answers for question number 6? Strict bed rest and elevation of foot is mandated. That is false. Inject sclerotherapy as an immediate treatment. That we can take it as true, right? Multi-layer compression stopping, again true. Saphenofemoral ligation and long saphenous stripping as an elective procedure, true. Thromboprophylaxis is warfarin. That is false, right? That is false. Sclerotherapy. Very good. Question number 12. Sclerotherapy is given for saphenopoperial incompetence. Yes, it's given. There are no contraindications as such. Sclerotherapy is again a different option, right? Asymptomatic people need treatment. That's false. You don't treat asymptomatic patients. Early disease is treated by graduated compressive stockings. That's true. Venous ulcers are treated with local antibiotic creams. If there's infection, you treat, but that is not a definitive treatment. You should treat the venous hypertension, right? DVT is a complication of varicose vein surgery. That is again true. You all want to discuss the theory part and get back to the question now? Shall we finish the questions on varicose veins? Then discuss the theory part. What do you prefer? Huh? 2D. It's not false. 2D is true. DVT is a complication of surgery. It's a rare complication of surgery, varicose vein surgery. You'll want to so theory first and then questions. Is that the way you all want? Right. We'll just quickly run through the theory part. Then we'll come to question that will be easy for majority to know. Yes, varicose veins. Its definition, it's the manifestation of chronic venous disease, right? Due to AIDS, there is a chronic venous hypertension, and that will manifest as dilated tortuous veins. Okay. Risk factors of varicose veins: female gender, obesity, age, family history, DVT, and congenital causes. Right? Pathophysiology. In the primary varicose veins, problem is in the superficial veins, either at the site of communication with deep veins or the valves of the superficial veins that which communicates with the deep veins perforators. Lot of those are not functioning, right? This is valvular incompetence, right? So, there will be regurgitation from deep veins to venous blood will be regurgitated from deep venous system to superficial venous system, and in superficial venous system also the valves are incompetent. There will be retrograde flow, and that will impede the anterograde flow, and there will be collection of pooling of venous blood in the veins, and it will engorge, and there will be a venous hypertension that will reduce the oxygenation to the stagnant area. Then skin will become fragile. There will be ulceration, right? And due to this exertion of fluids into interstitial compartment and deposition of proteins, this subdermal layers will be thickened and fibrous, and patient will develop lipodermatosclerosis, right? Those are the complications. Secondary varicose veins. Varicose veins due to another etiology can be occurred due to DVT or deep venous obstruction due to pelvic or intraabdominal tumors, right? So there's etiology which due to that patient will develop varicose veins, right? Clinical features: patient will complain of pain, swelling, heaviness of the limb, itching, and muscle cramps. And severity: antibiotic cream, 2LD. Venous ulcer, if it is infected, we can treat, but it's not definitive. We can take it as false. No? Venous ulcer, there is no actual indication for antibiotics. Severity is classified from C1 to C6, right? C1 is telangiectasia reticular veins, C2 varicose veins, C3 where the patient gets edema, C4 where patient develops complications with varicose veins, pigmentation and eczema, lipodermatosclerosis or atrophic blanche. C5 is heel ulcer and C6 is active ulcer. Right? From C4 onwards, patient has developed complications due to chronic venous hypertension. Investigations: venous duplex to study superficial and deep veins and to identify the site of incompetence, right? Contrast venopropy and this MR CT, those are we don't do usually. And management could be conservative or surgical intervention. Conservative management will be done by compression therapy, graduated compressive stockings. Interventions: either open surgery, as we discussed, subfemoral ligation and stripping, or stabilization, or minimal invasive surgery, sclerotherapy, or endovenous procedures. Radio frequency ablation, endovenous laser ablation, or stim therapy, or non-thermal neointimal therapies, right? Those are the management options. And compression, regarding compression therapy, graded compression does three things: reduces venous reflux, reduces venous stasis, and improves venous flow. Right? We apply class 2 or class 3 stockings with 18 to 24 millimeter mercury or 25 35 millimeter pressure. Problem is the compliance, because it should be weared every day, all time, and it will, wearing these stockings will make irritation and skin ulceration, and it's a bit uncomfortable, and compliance will be a problem. And if there's a occlusive artery disease, compression stockings will be contraindicated. Open surgery, again SFL and SPL, saphenofemoral ligation, saphenopropy ligation. Complications of surgery could be bleeding, hematoma, infection, nerve injury, saphenous or peroneal nerve injury, recurrence of varicose veins, and DVT. There's a question asking about this complication, right? DVT is a rare complication of open surgery. Even in endovascular ablation, there's a risk of DVT, because if you damage the deep vein endothelium, there's a risk of thrombosis. Sclerotherapy, injection of sclerosants into the vein, followed by compression to achieve occlusive fibrosis. We use chemical irritants like glycerin, osmotic irritants like hyperoxyline, detergent. That is, STD is the commonly used detergent. So sodium tetrahydroxy sulfate, right? We make foam, mix the 4 ml of STD with 16 cc of air and make foam, and then inject guided ultrasound guided injection of sclerosant into veins. Then compress the veins by compressive garments, stockings. So you make the irritation of endothelium of the veins by sclerosant, then compress the vascular venular wall to each other, then it will fibrose and occlude the lumen. Right? Contraindication of sclerotherapy are allergies and DVT. Problems are anaphylaxis, skin ulceration, and pigmentation. If extra vessels, if you put the sclerosants into outside vessels, that will lead to ulceration, to pigmentation. Right? Then comes this thermal ablation, endovascular procedures, radiofrequency ablation, and endovascular laser ablation. Right? You inject the tumor cells around the vein, then put a guide wire along the vein and apply the vascular lumen by thermal energy or laser energy. And that will again leads to fibrosis of the lumen and occlude the vessels, right? From endovenous procedures and this open surgery, what you do is you dislocate the superficial venous system from the venous system and remove the connection. So that will prevent the regurgitation of the venous blood to superficial venous system. Right? That is what you do. And venous system, there are deep and superficial venous system, right? This is a superficial venous system, right? There is a long saphenous and this is a long saphenous vein, greater saphenous vein, which runs from medial malleolus, anterior medial malleolus, and ascends in the medial ward of the limb, right? And drains into the femoral vein at the saphenous junction. And there are connections along its pathway. There are connections, perforators, which communicates with the superficial veins and the deep vein. Right? There are perforators. From this, if the perforators get incompetent, this saphenofemoral junction become incompetent, there will be retrograde flow from deep venous system. And in this superficial vein itself, if the valves are incompetent, there will be retrograde flow. Right? And this is the long saphenous vein, short saphenous vein, which drains into popliteal vein and the saphenopopliteal junction. It arises from the lateral board of the foot and runs behind the lateral malleolus. The deep veins system, posterior tibial, anterior tibial, and peroneal veins become popliteal vein and ascends as femoral vein and becomes the external iliac. This is the lipodermal sclerosis, skin induration, redness and hyperpigmentation involving lower third of the leg in a patient with stasis and dermatitis, and lipodermatosclerosis. Right? Skin induration, redness, hyperpigmentation. Those are the complications of chronic venous hypertension. Then skin will become subcutaneous tissues will become fibrous and develop lipodermatosclerosis, right? This is the typical picture of chronic venous hypertension. Lymphedema, lipodermatosclerosis, fibrosis panicularis, characterized by advanced hyperpigmentation and induration. This is an advanced form of lipodermatosclerosis, right? This is atrophic blanche, right? This is blanching and this is ulceration, right? Then yes, that's regarding venous diseases, right? Right. Question number 16. Varicose vein patients having chronic non-healing ulcer in the leg. Best appropriate management is. What is the answer for now? Question number 16. What is the answer for this? Devan, is chronic venous hyper is a not venous ulcer, but they haven't mentioned about the varicose vein severity. That means where is the incompetence, whether it is saphenofemoral, long saphenous territory or short saphenous territory. Where is the reflux is that is reflux is involved in saphenofemoral junction, saphenopodial junction, or is there a isolated perforator incomplete? So depending on these findings, the management will differ, right? It's not just uh, taking the system out, superficial venous system out, right? They say leg, can't you take as short of venous? Even in long venous territory involvement, you can get leg ulcers, right? So without that picture, you can't plan the treatment, right? But you won't wait until the wound gets healed. That because for you to get a wound, reason is the etiology is chronic venous hypertension. Due to this venous stagnation, this tissue, skin and subcutaneous tissue will be hypoxic and there's less nutrition, or fragile skin get damaged by minute trauma and get ulceration, and they will poor healing. So once you remove the venous hypertension, this also will start healing. So you have to treat the etiology. That means if there is a venous hypertension, you should find where is the reflux is, what is the system involved, whether it is short saphenous or long saphenous territory, and if in that where is the reflux is, sometimes isolated perforator reflux will lead to ulcer formation, right? So if you treat that isolated perforator, if you ligate the perforator, then that will be the treatment. So you have to plan according to the imaging findings. You can't answer a question without adequate information. So something is missing in this question. So you have to understand that it's not just blind surgery. Assess where the problem is and then intervene, right? Right. True. Question number 18. True or false regarding varicose veins in the lower leg? Stripping of the long saphenous vein is usually done up to the ankle. What do you say about 18A? 18A. Stripping of the long saphenous vein is usually done up to the ankle. Is it true or false? False. Why? Up to which level you do the stripping? Up to which level you do the stripping? Now, up to stripping means you remove the connection of the long saphenous vein to femoral vein, cut from that junction, and you put a guide wire and strip the long saphenous vein from saphenous junction to knee level, right? You don't strip the below knee part of the long saphenous vein because it will damage the saphenous nerve which accompanies the long saphenous, right? If you damage the saphenous nerve, patient will develop sensory impairment in the medial border of the foot and the upper part of the medial border of the leg as well. So to prevent that, you strip only up to the knee level, right? Sodium tetradecyl sulfate causes damage to the endothelium. That is the STD sclerosant. That is detergent we use for stereotherapy. We make foam and inject to the vein. That will damage the endothelium, and we put the compressive dressings. That's damage. Endothelium will come damaged endothelium will lie apart and that become fibrous and that will occlude the lumen. This dilated venous lumen. Chronic venous ulcer becomes Marjolini's ulcer. Yes, that is any non-healing ulcer can become malignant, and chronic venous ulcer also there is a possibility. Multi-layer elastic compression bandage is effective in the treatment of venous ulcer. Yes, that is a method of conservative treatment. Evaluation in duplex scan is indicated prior to surgery. That is true because you can't just do a blind surgery. Right? For you to plan the intervention, you should do the imaging. Right. Then 27. Oh, yeah. Varicose veins. Sclerotherapy is given for suffering of popliteal incontinence. Yes, you can give because there are no contraindications. Can give sclerotherapy. Asymptomatic people need treatment for falls. Early disease is treated by gradual compressive stockings. Yes, you can treat. And that is patient's wish and the clinical judgment. Early disease, you can try conservative methods. Venous ulcers are treated with local antivirus. That is false. DVD is a complication. Again, it's true. Then next question on venous disease. Varicose veins present with question number 44. Spontaneous hemorrhage. What do you say? What do you say about question number 44? True. Yes, they can bleed, right? Some patient comes with bleeding. Skin changes again. Yes, it's a complication. No? Eczema, atrophic blanche, lipodermatosclerosis, itching. Yes, again. Yes, malignant change. Yes, marginal ulcer. Saphenopharynx. What is saphenopharynx? All are true. What is saphenopharynx? Have you seen saphenopharynx? That is a differential diagnosis for your inguinal lungs, right? Have you seen saphenopharynx? Have you examined saphenopharynx? It's like your varicose in testicles, right? It reduced by lying down, reappears on standing, right? So again, appearance of engorged veins at the saphenofemoral junction due to saphenofemoral incompetence, right? Question number 54. 32-year-old woman is diagnosed with varicose veins during her second pregnancy. Inguinal hernia can differentiate kinds of varicose. How do you differentiate? Think and answer. It's cough impulse, no? And your bowel sounds, anatomical correlation. Right. So question of 54, a 32-year-old woman is diagnosed with varicose veins during her second pregnancy. Which of the following is the best management option? What is the answer for 54? Question of 54. Reassurance review, vascular referral, sclerotherapy, stabilization, tendon bulk procedure. It's basically self-limiting. Why do they get varicose veins in this pregnancy? Reason? Why do they get? You say for you to get varicose veins, there should be valve incompetence. Why do they get valve incompetence in pregnancy? Another thing is their fluid volume will be, yes, hormone actions will lead to valve incompetence, progesterone, estrogen activity. Right, and it will settle after termination of pregnancy, so you don't intervene. Follow up after the pregnancy. Question of 59. 57-year-old woman with varicose veins present with large jars over the left medial malleolus. This is associated surrounding lipodermatous eczema. Ankle brachial pressure index is, the leg is 1. Patient is moderate obese. What is the type of ulcer seen in this patient? What do you say? What do you say about question of 59? What is the answer? Yes, it's venous ulcer, no? Ankle brachial pressure index 1 is they have extruded arterial diseases, occlusive arterial disease, right? There are features suggestive of chronic venous hypertension and complications due to that lipodermatous and eczema. And it involves in the left medial malleolus gate area, common side of venous ulcer, right? Patient is obese and it's a risk factor. Female gender, all are risk factors for varicose veins. So it's more towards venous ulcer. Yes. Then 66-year-old female has long-standing arteriovenous ulcer of the lower leg. Over the past 6 months, one of the ulcers has become much worse. Despite a number of different topical therapies, it is increasing in size. What is the most likely cause of a presentation? What is the answer for question number 60? Yes, it should be likely cause, Marjorie, should be this malignant transformation, no? Long-standing ulcer with recent rapid worsening. Should be malignant transformation, ulcer. Right. Okay. Then we want to DVT. DVT deep vein thrombosis. It's usually presents as acute swollen limb, right? DDs could be, apart from DVT, ruptured Baker's cyst, erysipelas, cellulitis, muscle rupture, lymphedema, fasciitis. Pathophysiology, it's a dynamic condition, result from combination of risk factors that shifts the balance of coagulation to hypercoagulable state. As you know, orthostride states of blood, endothelial injury, and hypercoagulability contributes to the DVT. Thrombus, that venous thrombus usually forms around the valves on the endothelium, and there's tendency to propagate. Initially, it occurs in the calf veins, then involves the popliteal vein, then can progress in femoral vein, and it will complicate with phlegmocerebellar alba and phlegmocerebellar dolens. Phlegmocerebellar alba means limb will become pale due to arterial occlusion, then becomes ischemic. Yes. White leg, then sinus. Right. Then this. These factors: age, immobilization, surgery, trauma, malignancy, primary hypocoagulable states, history of DVT, family history, high estrogen activity, pregnancy and postpartum period, OCP, estrogen, obesity, catheterization and endothelial injury of the venous system, MI, and heart failure. Wells score, most widely used and validated clinical decision tool. Wells score compared D-dimer test guide the clinicians with regard to need for a duplex scan. Wells score, each of these will given 1 mark. If the total is less than 2, low risk. If the total is 2 or more, it's high risk. Active cancer within 6 months of palliation, occupation reason palliation, paralysis, recent immobilization of lower limb, recent bedridden for 3 days or major surgery within 4 weeks, entire leg swollen, calf swelling more than 3 centimeter, pitting edema, all are superficial variants of previous document. All are consider risk factors. Each will be given 1 mark. If the score is 2 or more, high risk of DVT. The varicose vein is a risk factor for DVT. Yes, DVT will manifest as varicose veins, and varicose vein itself is a risk factor for DVT. Imaging 2-point duplex scan looks at property and common femoral vein compressibility. If the duplex is inconclusive, then you have to think about venogram, CT and MRI venogram. Right? Treatment of DVT needs to treat immediately to prevent pulmonary embolism and stop thrombus propagation. 3 aspects: oral anticoagulation, compression therapy, and mobilization. Anticoagulation, immediate subcutaneous administration of therapeutic levels of low molecular weight heparins. Oral anticoagulation with vitamin K antagonists, warfarin. Low molecular weight heparin can be stopped after INR has reached the therapeutic range for 2 consecutive days. INR range for first time DVT is 2 to 3. Newer oral anticoagulants, so rivaroxaban, dabigatran, so also there's a place, right? Duration of treatment for DVT should be given at least 3 months of anticoagulation. Patient with malignancy, it should be 6 months. Patient with recurrent DVT, it should be lifelong anticoagulation. Compression therapy as soon as possible. Once the acute swelling is settled, switch to therapeutic elastic compressive stockings, initially short stretch bandages. Immediate mobilization through safe and does not increase risk of pulmonary embolism. Little bit regarding post-thrombotic syndrome, and these are catheter-directed thrombolysis. There's a place, right? Should be considered in ileofemoral. You won't give systemic thrombolysis for DVT, but catheter-guided thrombolysis in ileofemoral DVT. There's a place, right? That's the rough overview on DVT, right? There's another article. Thromboembolism. This is regarding thromboembolism. After surgery, DVT risk is 15 to 40%. After general procedure, after surgery, risk is double, right? Fatal pulmonary embolism risk is 0.2 to 0.9 in elective surgery, 0.1 to 0.2% in elective total hip replacement, and 2.5 to 7.5 in surgery for hip fractures. Though regarded as a surgical complication, most symptomatic venous thromboembolism events and fatal pulmonary embolism occur in medical patients. This thrombus, postmortem clot, and venous thrombosis, you know how to differentiate this chicken fat from a venous thrombosis. thrombus formation, hypercoagulability, endothelial damage, and stasis. Clinical features of DVT, non-specific symptoms and signs. Notable clinical signs, hormone signs. Close reflection of foot results in calf pain. Bancroft's or Moore's sign, compression of calf against tibia will cause pain. When the calf is compressed laterally. It's sign of posterior tibial DVT. Lowenberg sign, calf applied to calf and once pressure reached to 80 mmHg, rapid development of pain. Risk factors, acquired versus genetics. Acquired increased age, cancer, prolonged immunity, stroke, pregnancy, postpartum, previous thromboembolism, congestive heart failure, acute infection. Dehydration, hormonal treatment, OCP, long yard travel. Varicose veins risk factor, acute inflammatory bowel disease, rheumatological disease, nephrotic syndrome. Is again a hypercoagulable state. Atherosclerotic disease. In children, cancer and there's genetic component as well, right? Antithrombin deficiency, protein C deficiency, protein S deficiency. Those are anticoagulation factors. If it is deficient, there is a hypercoagulable state. Then factor for Leiden deficiency, and so on, right? Hydrogen factor deficiencies. Venous thrombosis spectrum, it can be uncomplicated DVT, complicated DVT, DVT secondary anatomic cause. Uncomplicated DVT, lower extremity DVT, proximal DVT, isolated distal DVT, upper extremity DVT, or splenic vein thrombosis, hepatic portal, infiltrate splenic vein thrombosis is also part of deep vein thrombosis. Complicated DVT means pulmonary embolism or post-thrombotic syndrome. Embolism, 1/3 will die, 2/3 will survive. Right? In those of 66% of surviving portion, majority has no lasting effects. Minority will develop chronic pulmonary hypertension. And if it is acute passive venous thrombosis, patient will die. Sudden death. Post-thrombotic syndrome occurs in about 30% of cases, usually within 1 year of DVT episode. Pregnancy albadolens. Seen in third trimester pregnancy when left common iliac vein is compressed against the pelvic rim by gravid uterus. Now more common in malignancy due to hypercoagulation. Complete obstruction of deep venous system of lower limbs without venous system. Leg now relies on superficial venous system to drain blood delivered by arterial system. Superficial venous system become inadequate, results in edema, pain, white appearance of leg. Occlusion of in this setup, if you occlude superficial venous system, it prevents all venous outflow and limb becomes more edematous, painful, and this will further impede the artery inflow, resulting in ischemia. That is the condition called phlegmasia ceruleum dolens. Right. Then embolic stroke. Emboli can escape into systemic circulation, leading to cerebral embolization if there is patent foramen over. Right, that is also a complication. This anatomic anomalies can lead to secondary DVT. Right? Left iliac vein compressed by the right iliac artery. Uncomplicated DVT, complicated DVT, pulmonary embolism, post-thrombotic syndrome, acute massive venous thrombosis, phlegmosis syndrome. It is secondary anatomic causes. Spaghetti syndromes, right? Management, uncomplicated DVT depends on the management depends on diagnosis, then categorize this uncomplicated, complicated, or DVT secondary anatomic causes, and there's a place for DVT prophylaxis as well. Treatment of DVT, venous thromboembolism, again depends on the severity, whether it is uncompleted, complicated, or anatomical derangement. Diagnosis is talked about very score, and we can support the Wellsco with D diamonds and confirm the diagnosis. I think time to discuss this. DVT likely scenario, if D diamond is positive but ultrasound is negative, repeat ultrasound scan. You won't this much of details, I think. We go to management. If we suspect pulmonary embolism, immediate CT pulmonary angiogram and immediate interim parenteral anticoagulation. Either you go for immediate CTP or you start anticoagulation, then do the CT pulmonary angiogram when available, right? If it is pulmonary embolism, unlikely to do the D diamond. If it is positive, go with angiogram. Right? D-dimer says there is a degradation products of cross-linked fibrin when broken down to plasma. Reflects global activation of blood coagulation and fibrosis, inflammation, pregnancy, malignancy, and elderly. There is false negative rates in previous heparin news. Rate presentation small below in DVT. Venous ultrasound scan. 3 types. Major criteria. Loss of phasic pattern, loss of response to absence of color. Those are the main in appearance. 95% sensitivity, 96% proximal DVT. For distal DVT, only 70% of sensitivity. Contrast sonography and MRI. Heparin, low molecular weight heparin, Parinax, underpumping drugs, then warfarin. Thrombotic therapy catheter guided. Systemic thrombotic therapy we don't usually give. Then mechanical intervention, IVC filters and compressive stockings. And usually what we give is low molecular weight heparin, and yes, we can give both the unfractioned heparin or low molecular weight heparin. There are different advantages on both of them, right? Low extremity proximal DVT. If it is provoked by surgery, anticoagulation for 3 months. If it is provoked by non-surgical process. Anticoagulation for 3 months, even if bleeding risk is low to moderate. If it's unprovoked, anticoagulation for more than 3 months, even if bleeding risk is low to moderate. Right? That is a recommendation. It is second unprovoked is same as above. For cancellation, extended anticoagulation greater than 3 months because risk of thrombosis is very high. Pulmonary embolism, unless contraindicated, full dose of anticoagulation should be initiated. Continue parenteral anticoagulation minimum 5 days until INR is 2 or more for at least 24 hours. In massive pulmonary embolism, unstable pulmonary embolism with right heart strain on echo, catheter-directed systemic thrombotic therapy should be given. Right? That is regarding pulmonary embolism management. Inflammatory syndromes, again, catheter-directed thrombolysis should be done to salvage the limb. If it is developed, if the deep vein thrombosis complicated compartment syndrome, fasciotomy should be done. Right. Prophylaxis again, mechanical and pharmacological prophylaxis, compressed stockings, pneumatic compressions, right? Then pharmacological prophylaxis. Right, that will be enough for you all. I think we'll go with the questions and try to finish at least DVD questions. Thromboembolism. Varicose vein is a risk factor. What is the answer for this? True, yes, it's a risk factor. Enoxaparin is best than heparin in treatment. We can't say what is best. Both have different advantages, right? But what we use is enoxaparin. Enoxaparin is better. We don't have to monitor with APTT regularly. But when you want to reverse the action, it's difficult. Huh? Prophylactic dose heparin has effect on thrombolysis. That is false, right? They don't have effect on thrombolysis. Compression is effective during surgery. That is true. I think enoxaparin thing is no one says it's best. Spirit of a dilemma here for regarding B. What do you say? 17B. True or false? There's the advantage of monitoring. That's true, but with regard varicose veins are superficial, so don't cause thromboembolism. Now there's a risk of stagnation. It is a risk factors for thrombosis, right? Varicose vein itself. Better if a recommended guideline, right? This first prolonged is a chronic venous hypertension. It's a risk factor. This is stagnation, one part of Virchow. 28. Regarding DVD management, percutaneous cable filters are mandated. It's not mandatory always, right? when do you put cable filters? If patient cannot give, patient can is having complications, so you can, if you can't give medical treatment for patient, or otherwise what's your anticoagulation. Other thing is two indications. One is failed medical treatment. Other thing is pliable thrombus, no, propagating. Maybe there are two indications. Anyway, not mandatory. Immediately start heparin. Yes. Thrombolysis is contraindicated. Systemic thrombolysis is, I think, contraindicated, not the local thrombolysis. You can give the thrombolysis by catheters to the clot, so it's not contraindicated. Warfarin for 6 months, yes, usually 3 months, and massive ilofemoral, try to give thrombotic agents through catheters, right? Go to the clot and inject, not as the systemic thrombolysis in myocardial infarction, but not in DVT. Right. Then regarding DVT treated with low molecular heparin, diagnosed by venogram. You can do venogram and diagnose, but not we don't do usually. Causes superficial thrombolysis of weights. Again, yes, it's a complication of DVT. All are true. "50-year-old woman, 30 did you do? 45-year-old female underwent surgery. Following that, she developed uncomplicated DVT. Yes. What is the most appropriate next investigation? Next treatment option. What is the next treatment option? Yes, it's low molecular heparin, right? After surgery, once you are sure with hemostasis and know if there's no bleeding, you can start low molecular heparin. So it should be the answer. "36, 50-year-old woman diagnosed with ilofemoral deep vein thrombosis following anti-resection. In this patient, early mobilization is associated with greater risk of pulmonary. That is false, right? That is false. Early mobilization is advantage. That should be encouraged, right? Treatment is initially heparin, true. Cable filter is not recommended at this stage. This initial stage, you don't need, right? It's true. Warfarin therapy should be continued for up to 6 months. True. Long-term aspirin, that is false. You don't give antiplatelets. Why do you give antiplatelets for DVT? It's thrombus, no? It's anticoagulation, right? "38. DVT post-operation occurs in less than 5% patients undergoing total knee replacement. Less than 5, nearly 2, 3, no? Sure what is data. There was usually begins to form in the early post-op period. Venous ulcer developed chronic venous hypertension unless patient they get complicated with post-thrombotic syndrome, they won't develop. Anyway, there's a risk for even in post-thrombotic syndrome they develop. Usually of little clinical significance, that is false. Initial treatment is subcutaneous enoxaparin better than contraction heparin. That is actually can't say. Did you all get any teaching on this? 38E. I'll check and let you know, right? Knee replacement business. So, 2.5 to 7.5% in surgery for hip fractures. There is general surgery considered 15 to 40%. So it should be more than 5%. No? It should be false because it should be more than this. No? DVT, you can give enoxaparin and fractionable both. What is better? It's a bit problematic. Anyway, I'll check. I think both can be used. One can say what is better, but what we use is enoxaparin. We'll see. 'Please repeat the answers for 30. Anyway, I get back to it. '55, 26-year female factor for development of sin, right? Not the nephritic. Obviously, aspirin is not a risk factor, right? Then right, those are basically questions on deep vein thrombosis. What is 38 again? Yes, A true, B true, C true, D false, E actually not sure. Can't say it's better, right? I'll anyway check with you. A false less than 5 it is nearly 40%, no? After normal surgery. In total knee replacement, it should be more than that. But risk of DVT. Risk of DVT. We don't see much now setup anyway. Oh, yeah, that's what they say now. Following general procedure, 15 to 40% risk. Following hip surgery, risk is double. Right. Okay. Then was the third April. Question number 19. 30-year-old female presented with iliofemoral DVT 1 week after C-section. Regarding her management, can you answer this? This is the last question of the day. Question number 19. Can you answer? Breastfeeding is not recommended. False. Early mobilization is not recommended. False. Long-term aspirin is recommended. False. Commencement treatment is heparin. It's true. Often must be continued for at least 3 months. That's again true. Okay. Right. Okay, that's it for the day. Right. That's it for the day. We'll see you later. Anyway, we couldn't touch on this lymphedema, then aortic aneurysm and carotid artery diseases. We'll try to finish in another day. Now it's 12:20. Time is up, no? Right. See you then. Good night.